Welcome to the Geriatrics podcast. This is Eric Wadera.
This is Alex Smith.
Alex, who do we have with us today? We are at the AAHPNA.
Was it a long night last night? Were you at the Jerry Powell pub crawl?
I may have been at the Jerry Powell.
What time did you get home, young man?
2:30 a.m. Actually, that's when we ended.
Yeah.
Alex, who's with us today at
Today
the
we're delighted.
HPM meeting?
We have Corita Grudzen. Was that right? Oh, damn. Grudzen. Corita Grudzen, who is an emergency medicine physician, and she's at Memorial Sloan Kettering. She's a researcher, and we're going to hear more about her research soon. And we have Kate Courtright, who's at the University of Pennsylvania, the Pear Center. They study palliative care. She's pulmonary critical care and palliative medicine trained. And we have Tom LeBlanc, who's from Duke, who is also palliative care trained and an oncologist. Welcome, Corita and Kate and Tom.
Thank you.
Thank you.
So we got a lot to cover today. We're going to be covering kind of what you're going to be presenting at the State of the Science tomorrow. So this is pre-recorded. But before we do that, we have a song request from
No, we don't. They failed to give me a song request. Therefore, they're being punished. And they have to sing along to my cheesy choice of Feel Like Making Science. Feel Like Making Science,
all singing
originally by
along.
Bad Company. And everybody's going to sing, including Ann Kelly, who's filming us over there. Ann, you want to say hi?
Hi.
Here we go. Let's see how this goes. Here we go. Baby, when I think about you, think about science. Darling, don't live without you and your science. If I had those golden dreams of my science, I would wrap you in the heaven till I'm dying. Feel like making. Feel like making. Feel like making. Feel like making science with you.
Oh, that was great.
Song request will always be honored in the future.
Lesson learned.
Learned.
Okay, we got 3 trials to talk about. These are like big trials in palliative care, and kind of is there a similar theme here? Let's just jump into the trials. Kate, I'm going to start with you
Okay.
in your trial,
Okay.
behavioral economics trial, right?
Yes.
Why did you decide to do this trial?
Because we have a problem in the ICU with communication.
What's that problem?
The problem is we communicate late. We share prognosis late. We elicit goals and values late. And so all the time while they're in the ICU getting prolonged intensive care, we don't really know that we're providing goal concordant care. So we wanted to nudge it a little upstream.
Nudge it.
Nudge it.
Nudges. Behavioral economics. We've certainly talked about that before.
We have.
Alex makes fun of me because I bring up that podcast every single podcast. Real quickly for our audience, what's a nudge?
So a nudge in its simplest form is really any change to choice architecture. Or like a choice frame in which you are trying to overcome inherent human decision-making biases to guide people gently towards a desired choice that is in theirs or others' best interest. And it neither restricts nor incentivizes choice.
So that really expensive surf and turf meal that I saw on the menu last night, that probably not a lot of people ordered. That really cheap one, it's going to nudge me towards one of those middle items.
That's one. Yep, expanded choice sets, that's a marketing technique. Yep.
Okay. So what did you do in the trial?
In the trial, we tested 2 nudges. One was called a focusing effect. So we all, when bombarded with information, sort of have to take certain elements of a decision and focus on those. And in the ICU, you can imagine we're bombarded with information a lot. And so what we did was ask clinicians earlier in the ICU stay for very sick patients to document prognosis, and for those who they thought would survive, to document 6-month functional prognosis. And that helped them focus on that instead of, say, the blood pressure, the vasopressors, or the ventilator settings that day.
And how did you do that?
So it's an embedded alert in the electronic health record, and they just clicked those 2 answers very quickly.
Oh, yeah?
And then the second intervention was called accountable justification, whereby we simply asked those same clinicians if they had offered these patients the option of withdrawal of life support and comfort-focused care, as is recommended by guidelines for high-risk patients, and if not, why not? And that's it.
Those are the 2 nudges.
Yep.
You're not telling him what to do.
Correct.
You're giving him options.
Correct.
But you're reminding them.
We're reminding them in a way, and also leveraging, again, that idea that we all have these biases. And so when you, for example, in accountable justification, you're simply leveraging the fact that clinicians are trained to make decisions backed by reason and to document them. And this is no different.
And who were the patients including in this trial again?
Yeah, so these are very sick patients. These are patients who had a pre-existing chronic disease, very broadly defined. Were received.
Can you give me an example?
Sure, COPD, heart failure, solid oncology, hematologic malignancy, dementia, ALS, interstitial lung disease, several others. There were 9. There were 9 disease categories. Really wanted it to be generally applicable to an ICU population. And then they had to be receiving 48 hours of continuous mechanical ventilation at a minimum and be an adult.
Oh, wow.
So really broad, but also very sick.
And then before we get into the results, so they got these alerts. Exactly when did they get these alerts in there?
Yeah. So
on admission, are you telling them think about withdrawal and life-sustaining treatments?
no, they received the alerts at the time an eligible patient reached that 48 hours of continuous mechanical ventilation. Okay. And then they could respond to them at any time. We didn't tell them when they had to. Yeah. And that's when they got them. When they got enrolled.
Okay. Before we go on to the results, questions? Either of you have questions about the study?
Where was it done?
It was done in 10 hospitals, 17 ICUs, and Atrium Health.
Okay.
Yeah, down in North Carolina.
So, Kate, how many people were enrolled in this study?
3,500.
3,500 people. That's a pretty big palliative care study. And did nudging work?
It depends. So the asking clinicians to document prognosis did not change the primary outcome of hospital length of stay or really any of the secondary outcomes, which I'll get into. Asking clinicians whether they had offered the option of withdrawal of life support and comfort-focused care also did not change length of stay, but did increase the discharges to hospice odds greater than 2-fold, whether it was done alone or in combination with the prognostication nudge. And the same nudge, the withdrawal of life support nudge, also decreased the time to comfort care orders. But importantly, it did not change the frequency of comfort care orders. It did not change the frequency of palliative care consultation, the timing of such, or ICU mortality or 6-month mortality.
Huh. So how do you put that all together?
To me, it suggests that that nudge helped clinicians identify and discuss earlier likely prognosis and goals and values, such that patients who were likely to go on and die in the ICU with comfort care did so earlier in their stay. But more patients didn't die. Patients who would go on to survive likely didn't die because the mortality curves all converged.
Huh. Alex, you got a question?
So we had you on just recently, the podcast. We've had you on twice before, I think. So
Sounds right.
Recently you talked about the other trial, also with a nudge, and that was non-cancer, serious illness. Also the same hospital system?
No, that was in Ascension Health, and it was hospitalized patients who may have been in the ICU. This was ICU only.
ICU only, yeah. So what other than those differences, what do you draw from these two trials together? Like what lessons learned?
Yeah.
Or how would you contrast the findings?
I think the main one for me, being asked on the fly, is that one of them nudged specialist palliative care consultation, which we know has limitations, right? In that trial, not all of the consults that were accepted were actually able to be seen because of resource constraints. In this Ponder ICU trial, we didn't rely on palliative care specialists. We engaged bedside clinicians to have ICU communication and adhere to guidelines. And so none of the changes that we saw in end-of-life care processes relied on specialist palliative care increases or resources, which is really important because 7 of the 10 hospitals that participated were rural or community-based, which is where most Americans receive their care and also where specialist palliative care is often most limited.
Thank you.
So next, what should we do with this study?
Yeah. So some of the thoughts I've had in thinking about this are, we did not require communication training and education of the clinicians. And I think had we done so, particularly now that it's so much more accessible through, web-based courses with CAPC and other such platforms, that perhaps benefits would have been even greater. Mm-hmm. I am part of some other work in the ICU world, looking at time-limited trials and trying to better define what those are, how we talk about them with patients and families. And I suppose you could imagine a world in which time-limited trials are somehow combined with this nudge to make sure that we're offering the option of withdrawal of life support and comfort-focused care, because that's one of the options in a time that may end a time-limited trial. Mm-hmm. Other thoughts are that the combined interventions, when we put them together, is a little bit fishy to me, or squirrely, I guess. You don't know if the treatment alternative intervention is what drove those findings. It sure seems like it because it was the active intervention arm, and prognostication didn't seem to do anything on its own. So I don't know, we want to try to minimize nudges and burden in the EHR. And so might you just use the one intervention and not pair it with the prognostication intervention?
Last question. So you asked a bunch of doctors in the ICU prognosis questions.
Yeah.
Should we expect a future study seeing how good those physicians are with their estimated prognosis?
Yeah. I mean, we absolutely will be looking at that, right? But we actually know they're not that great. A colleague of mine up in Toronto did an ICU study actually asking clinicians, nurses, docs, 6-month prognosis, both functional and vital status, and compared it with actual observed status. And nurses were, I don't want to misspeak because now I forget, it's many years ago, but we weren't that great is the upshot, which is why in this study, we don't make them do anything with the information. We don't make them tell patients. We just ask them to consider it. And in the end, if you put those findings together, they really did sort of rise to the top, the patients who were really the sickest.
Okay, next study. I'm going to go to stem cell transplants. So why did you do this study?
So we did this study because patients who go through the stem cell transplant process face a lot of misery in terms of physical symptoms, psychological distress, anxiety, depression, and even a risk of PTSD afterwards, sort of like a medical trauma, you might think of it. So there is a lot of literature suggesting that standard transplant care doesn't really meet the needs of these patients and their caregivers.
Okay, I got a second follow-up question to that. If memory serves me correct, Tom, you were a second author on a randomized control trial on stem cell transplant paper, showing that palliative care, in addition to usual care, improved a whole bunch of outcomes.
Yes.
And you decided to do a follow-up study on this. This is a follow-up study, right? Why another study?
Yeah, so Arij El-Jawari, the PI of that study and this one, had done that as a single-site study at MGH. So the idea is if it works at MGH, that's a special kind of a place. Maybe they do palliative care differently. Maybe they have better resources. Would this work at other transplant centers that have different kinds of clinicians or that serve different kinds of patients?
Yeah.
So we wanted to have diversity of sites and clinicians and patients.
Great. So how many different sites did you include in this study?
3 sites. So MGH is the primary site. Duke, and then UW, the Fred Hutch in Seattle.
Great. And so the intervention was usual care and palliative care. What was in that palliative care syringe?
Yeah, the patients randomized to the palliative care intervention were seen at least twice per week by palliative care specialists. It could be an NP, a PA, or an MD. They weren't seen by the interdisciplinary team.
Okay.
But they were seen by a specialist at least twice per week during the transplant hospital stay only.
And that's similar to the 2016 JAMA paper, right?
Yeah, it's really the same intervention, just a multi-site version of the study.
Okay.
And I think you're also getting at what did these clinicians do? What did they focus on? It really is just good palliative care for people with significant symptoms and distress. So it was not a heavily manualized intervention.
Yeah.
There's a training that basically told the clinicians, this is what transplant is like. Here are the common things that you should expect.
Yeah.
Like these patients get mucositis and it can be really bad and you should really think about early use of a PCA.
Yeah.
There's significant refractory nausea despite usual antiemetics. You should think about what else you could do to address that. There are issues with coping, uncertainty, anxiety, depression, etc.
Yeah. And if memory serves me correct, in the last trial, I'm guessing it's similar to this one, the focus was not on advanced care planning, life-sustaining treatments, any of that. Is that right?
Yeah, that's right. And the key is that these are patients with blood cancers that are usually in remission, but that have a high likelihood of coming back and leading to their death, usually pretty soon if we don't do something more aggressive like a transplant. So the idea is the transplant is a consolidative treatment that gives them a chance at cure. And with that chance at cure comes significant risk of death in the short term and this very bothersome, difficult hospitalization with all these symptoms and issues. So the intervention is really an extra layer of support when you're going through this very difficult thing, but cheering these patients and families along, hoping that they will be cured, but making it hopefully a little bit easier to get through the misery of a transplant.
And we're going to get to results, but that's why I also love that 2016
Yes.
paper. I think it was the very first palliative care trial that ever looked at individuals getting cured of therapy.
That's probably true. It was the first randomized palliative care trial in hematology.
Yeah.
Is the way that I think of it.
Yeah.
But yeah.
I think about it as the first one
Yeah.
that addressed, individuals cured of therapy. So what did this one show? Did it negate everything from the 2016 trial? Palliative care doesn't work.
Thankfully not. No. And there are some minor nuances and differences in some of the outcomes and such, but the primary outcome was assessed at 2 weeks into the transplant hospital stay, and on the patient-reported outcome measures at that time point, which is when these patients feel at their worst, things like quality of life, anxiety, depression, overall symptoms, fatigue, PTSD symptoms, really all of those things improved except for anxiety. These were clinically significant and statistically significant improvements. But then we looked also a little bit long-term at 3 and 6 months, and we also looked at caregiver outcomes. And it's pretty interesting to see what came of it.
Well, let's talk about caregivers. But before I do, because the last time I think anxiety actually improved, right?
I think in the single-site study it did. Yeah.
Okay.
In this case, there was a difference at baseline where the groups, just even with the randomization, happened to be a little different. And I think that might be why we didn't see the statistical effect, but I don't know.
And then for caregivers, what was the caregiver outcome?
We looked at a few different caregiver outcomes, anxiety, depression, and there actually was less anxiety in caregivers 2 weeks in at that main primary outcome assessment.
That's great.
Yeah. So what's interesting, there was no caregiver intervention, but the idea would be that if you take better care of the person that they care about and love, that they're somehow perceiving that person's getting better symptom management or distress management, or maybe they're part of the conversations about the uncertainties and the worries of transplant, and whatever that did, it translated into less anxiety for them.
Okay. Last question for you on this. We got a question for Alex. Is how does this second randomized controlled trial on palliative care consultation in stem cell transplant patients, How does it compare to are there multiple randomized control trials of cardiology consults for stem cell transplant patients, or ID consults for stem cell or endocrine consults for stem cell transplant patients?
Not that I know of. No, it's shocking, isn't it?
Loves that question. Why do we have to keep proving it?
Yeah, I guess. Yeah. Case question: Why do you feel like we need to prove, not just on a single site but multi-site study, that a palliative care consultation improves outcomes for this specific population?
I think ultimately it's because usually my transplant colleagues don't believe that this is necessary.
Yeah.
And we have to prove that it is helpful. And when the case in point example here is when that first trial, the single site trial you were talking about, was opening, we had the opportunity to be a second site. And we were planning to just kind of do it with no funding and figure it out because it was important. And when I presented it to the transplant team, they said, this is interesting, but we don't need that. We have our social workers and our psychologists, and we know how to manage these symptoms. They're because of the treatment. We have protocols to address pain and nausea, et cetera. We don't think that this is really necessary, and so we don't think that we want to participate.
Okay.
And of course, that was wrong. But when you do a study like this at one site that's a unique place, people say, well, that's fine, but we don't need that here. Hopefully that doesn't mean we need to do a 20-site study in transplant now, although actually we are doing that in a different disease space in AML, but for a different reason. That'll be another podcast, I guess.
My question is very related to Eric's. One of the places I trained, I won't name, but it's not easy to figure it out. That I think I did one palliative care consult in 3 years in stem cell transplant. And then in that case, it was like we have very clear restrictions placed on our consult. Like we could talk about depression, but not anxiety, because that might bring up what they were anxious about, and that might be problematic. Are you seeing attitudinal changes? What is it about transplant in this case that seems to be maybe different than others? Or is it not? Is it just like, at first oncologists were resistant for a solid tumor, and then we had a change with studies coming out. What do you think?
Yeah, I think it is different. So I treat patients with acute leukemias and related diseases. So I kind of know some of this from my own clinical practice. And when you are treating somebody with a really aggressive regimen, you are kind of bringing them to the brink of death sometimes and sort of dangling them over the cliff and pulling them back by their coattails. And we've all had cases where somebody who didn't really know and understand what we were doing and what we would expect to see and what was normal and what's likely to improve versus what isn't would, in a well-intentioned way but harmful way, ultimately recommend something or do something for a patient that wasn't the right thing. And it's just created trust issues over the years. And so I think many transplant docs have had a situation where one of their patients was in an ICU and somebody talked with that person about goals of care when they had a very reversible issue, like some acute graft versus host disease or alveolar hemorrhage or sepsis or something that is an expected course of transplant for a small proportion of people. And, when you look at the critical care evidence, it's clear that patients with a blood cancer are highly likely to actually leave the ICU and leave the hospital and be functional compared to a patient with an advanced solid tumor, where if they're in the ICU, it's usually really bad. And it's usually because of the cancer. And often that means we shouldn't be doing very, very aggressive things. I mean, certainly there's exceptions, but I do think it's different.
Yeah, thank you.
So maybe not the nudging question about life-sustaining treatments for the stem cell transplant patients.
Yeah. It was our lowest, second to lowest enrollment, actually. It was hematologic malignancies in that study, yeah.
Okay. So we've talked about the ICU. We've talked about stem cell transplant wards, emergency room.
Yes. We went in reverse order. I don't know what happened there.
Yeah.
To all of our emergency medicine colleagues,
Start in the
the best for the last.
Okay.
So
We should have had you sing Urgent Emergency.
Is that a song?
I don't know if that's the name of it, actually.
okay, so let's talk about the emergency room. What did you do in your study?
So I guess I'll start with what we did and why we did it quickly. So we were really interested in patients that come to the ED with serious illness and go home. Because as many people know, when someone gets admitted from the ED, there's a whole host of resources you get when you're discharged after an inpatient stay that is already in place in hospitals all over the world because of readmission penalties, et cetera. So we were really interested in the gap that exists after patients leave the ED or in observation status and go home. So what we did is we randomized patients. It was patient-level randomization to either nurse-led telephonic care for 6 months or specialty outpatient palliative care for 6 months.
Okay. So we just did a podcast on creating palliative care consults. It was the default palliative care consult podcast where it was just layered on top of existing palliative care resources. Was this the same where were these two resources already there? Am I making this up? No, I am.
Okay, I'm like, what are you talking about? Yeah, I thought you were going to talk about the Beckelman study.
It's been a late night.
Yeah. It's not night yet. You mean last night?
Well,
It would have been more interesting if we did this on the pub crawl. We could have done the interview then.
when you go to sleep at 3:00 in the morning, it was when I talk about night. It was today. It was the night that I was still awake at. Well, I guess the question is, were both of these already staffed up and you just tested them, or did you give resources to both of them to do this intervention?
Great question. So it was funded by PCORI. So you cannot, PCORI does not pay for the intervention because you're comparing things that are standard of care. So we chose sites specifically that had outpatient specialty palliative care already. They had functioning clinics that were willing to see patients. And then with the nurse-led telephonic case management, that was a centralized model at NYU, and we got philanthropic support to hire the nurses. And they delivered, they were licensed in all of the states, but they delivered the care from NYU. And those were nurses that were hired specifically for this purpose.
And were there set amounts of time that either the palliative care consult team had to see patients or the nurses had to see or call patients? Or
So nurses, they also had specific training requirements. So I just want to make it clear, these were not just, it wasn't just any nurse. There were a number of things. They had to be certified in hospice and palliative nursing, and they had a whole bunch of other trainings that happy to,
These were palliative care nurses in a way.
Yes. And they got additional training in motivational interviewing, and they did the CAPC modules, and they did respecting choices. So they called the patient within 48 to 72 hours after an ED visit or an OB stay to do an initial assessment. And then they called patients every couple weeks for the 6 months. Palliative care outpatient was a single visit a month for 6 months. We started pre-pandemic, and very quickly it went to telehealth. So it was primarily telehealth. Most places had one visit that had to be face-to-face because of prescribing and regulatory issues, but it was primarily telehealth.
Okay. And how often did the palliative care team have to see folks?
It was one visit a month.
One visit a month.
Yeah.
Okay. So there's a palliative kind of nursing intervention versus a palliative. And what was the team in the palliative care side? It was
a clinic. So clinic visit. Your typical outpatient palliative care. Some of them were just a doc, an APP.
So kind of pragmatic trial, whatever was.
Pragmatic comparative effectiveness. There was no control group.
Okay. What did you find?
So we found that the outcomes in both groups were identical. So we found our primary outcome was quality of life. At 6 months, it was a change score. So both groups improved their quality of life. They were identical improvements. We found all of our secondary outcomes, ED revisits, inpatient hospitalizations, inpatient days, hospice use, loneliness, and symptom scores were identical between the treatment arms. There were big differences. We stratified by cancer and end-stage organ disease. So there were big differences between cancer and end-stage organ failure, but there were literally no differences in outcomes between nurse-led so nurses calling patients on the phone and going and seeing a doctor or NP or PA in clinic.
Did you measure, because one of the questions in palliative care is, is it just attention? Is it giving people attention? Is that what we're seeing as far as the potential benefit? Whether it be stem cell transplant patients where you're seeing them twice a week, it's additional contact, it's attention. It could be palliative care team. It could be a chaplain. It could be a volunteer high school student. My son just started volunteering for the VA.
Therapy dog.
Therapy dog.
Well, they refer them to hospice. So as far as I know, I don't think your son or the dog could do that. So that not so much.
My contact time, like, was there significant more?
Much more in the nursing arm. And people they voted with their feet. So we had much better, about 3/4 of patients finished the 6-month intervention in the nursing arm. People were not as interested in outpatient palliative care. It was very difficult. We put a couple extra things in place to really try to reschedule appointments and this was telehealth even. With that as an option, only about 60% of people even made one visit. With a lot of help in trying to schedule those. So, and then we did a per protocol analysis. So we know that even as a sensitivity analysis, because there was more uptake in the telephonic arm. So we compared per protocol. We looked at by functional status. We looked at minoritized groups. There was still no difference.
So what's your take on, like, what should we do with this?
So it's a great question. I think we don't have enough outpatient. What I don't think should happen, which happened at one of our sites, is they shut down outpatient palliative care completely. And that was not related to our study. It was right before. It was financial decision by the health system. But I think it's a way, we don't have enough outpatient palliative care. Every place that we conducted this, all 19 sites, never had enough appointments in the right time frame, other than one site that's a cancer center that just had more availability. So I think this is a way to extend the reach of outpatient palliative care. Patients love it. Cost was not one of our outcomes, but I think it's clear that paying for an RN is cheaper than having a doctor and having a brick and mortar clinic, even if telehealth is a part of that. So the question is, how do you pay for it? Because there's no payment model unless you're in an integrated health system or MA plans. So it's complicated because right now there's no mechanism to get it other than cost avoidance.
Yeah. Tom, I'm going to go to you on this one. Your stem cell transplant patient. What if it was, should the next study be a palliative care team seeing the patient twice a week versus telephonic RN from a central site checking up on them?
Yeah, it's an interesting idea. In this case, really a big part of the secret sauce, I think, is the symptom management piece, though, where you really need the clinical team member assessing and addressing symptoms and prescribing.
Yeah.
So I expect it would be helpful with the anxiety and depression issues, the coping issues, maybe the caregiver issues if you did this in a telephonic way with a nursing intervention. But if there wasn't the ability to prescribe and do the aggressive symptom management, I don't think we would have seen the same kind of.
Well, that's the interesting thing, is that we found that symptoms decreased in both of our arms equally. So we don't quite understand that. I mean, the nurses, every site was on Epic, so even though they were centralized, they would reach out to the team at the patient's health system, but somehow they still improve symptoms, which that's one of the things that we're trying to figure out.
Do you think they relayed that info to the primary?
They absolutely did.
Prescribed it?
I don't know if they actually prescribed it because we don't have access to that, but they definitely relate it.
No, that makes sense. When Ethan Bash did his study with PROs at Sloan Kettering, they had nurses receiving the weekly symptom alerts from these patients with advanced cancer getting palliative chemotherapies, and that led to significant improvements in ED presentations, quality of life, and even overall survival because they recognized problematic symptoms that needed attention and got it to somebody who would do something further about it.
Right. And same with Beckelman's study, who you guys just had a podcast about. Mm-hmm.
So let me ask you this question. Because getting the appointments for outpatient palliative care was a challenge, it sounded like. Is that right? Yeah.
I mean, so part of it wasn't just getting it was getting it at a time the patient could come, making sure they had transport. We even gave people money for transport, gave them $20 to pay for a cab or whatever.
And how much of the pragmatic trial, you're using existing resources to do these consults and potentially increasing the amount of workload that they're doing. And do you have data on what make these 19 different sites, you said?
Yes.
Like, how many of them have their own palliative care RN? I got to say, like, our our clinic has a palliative care RN. She is amazing in like doing the follow-up and contacting people. And I can't imagine an outpatient clinic without a palliative care RN. Do you have a sense of how many of these clinics have that resource?
We are looking at that now. We're just submitting a paper about not just the palliative care RN, but what are the differences? Were they embedded? Were they standalone clinics? Like what made things more likely for patients to follow up? So we're looking at a number of those factors. Did they have social work? Did they have a pharmacist? Did they, so how many appointments did they have in a week for new visits? So some would have 4, and we have one site that had 52.
Yeah.
So very, very different level of access. So there's a lot of factors. Yes, RN is one, but many others too, I think.
Yeah, and especially as palliative care gets clinics get busier and busier. When your next appointment is 4 to 6 weeks out for a palliative care appointment, it's hard. Alex, you got a question?
Yeah. Thank you. I'm interested in, from all three of you, or any of you, hearing each other's studies, what you take away from this. These are 3 trials, 3 of the highest rated abstracts at the State of the Science, which is relatively new meeting here. But it's incredible that 3 trials rose to the top here. And it's great that we're doing trials at this time. Other lessons, or what do you take away from this?
I'm really excited that the level of evidence, the bar is continually being raised in our field. So I remember when I was training, we often didn't have data to guide what we were doing, and yet we had lots of important clinical questions that needed to be answered. We still have a lot of questions, but we actually have some answers now and some data about things that we didn't, and it seems to be growing exponentially. So that's pretty neat.
I'm really excited that all 3 trials have incredible practical approaches. They all have limitations, for sure. Corita, you just discussed yours. We certainly have them, and Tom, I'm sure you did as well. But sort of if you boil them down, these are practical ways to deliver palliative care, and all of them have some evidence that some part of it worked. It makes patients and families feel better, and outcomes better, and quality of care better, and we can implement it.
We need more, though. That's all I have to say. We need a lot more than 3. Yeah.
But I got to say, the fact that we have 3 randomized control trials that we're talking about the state of science in palliative care is impressive, because historically that's not the case.
Yeah. Well, there's been an investment by Picori that invested almost $100,000. Now we're going to have this.
NIH,
NIH is now investing. It was, I think, $70 million was the investment from Picori, something like that. Yeah.
It sounds like they're feeling like they want to make some science.
They want to make some sense.
Oh my God.
Great segue. All right, are we ready to sing? Ann, did you have any questions? No? Good? Okay. Baby, when I think about you, I think about love. Science. Darling, can't live without you and your science. If I had those golden dreams of my science, I would wrap you in the heaven till I'm dying. Feel like making. I feel like making. Whoa. Feel like making science with you.
Thank you for being on this Jerry Pal podcast. That was wonderful.
Thanks for having me.
Thank you. That was super fun.
And sorry to all of our listeners for me being out of it, because we got home real late last night, but hopefully it wasn't too bad. And thank you for all your support. And we'd also like to thank all of our listeners who've donated more than $250, including
Dwayne Dobschutz, Frisch Brandt, My Lasting Letters, Kelly Strait, Daryl Owens, Roseanne Leipzig, Elizabeth Chung, Emise Shimoji, Harry Hahn, Nick Schneeman, Ed Martin, Jeff and Lena Galbraith, Himashu Malhotra, Nina Flanagan, Penelope Thompson, Lloyd Woolstat, Mark Wren, Carol Heyman, Bob Rixey, Patrick Lally, Annie Hargadon, Susan Nelson, and Sharon Brangman.
Thank you all.